So I'm going to give a brief introduction to the System C and Graphnet Care Alliance, and I'm going to have a conversation style with Rob specifically about medicines management at the ICS level. So could you go to the next slide, please, Rob? Thank you. So the System C and Graphnet Care Alliance is an alliance of 4 British companies: System C, Graphnet, Liquid Logic, and the latest edition, CareFlow Medicines Management, which was formerly Wellsky. We've got about 900, well, we've got over 900 people across the alliance now. Most of those have either worked in the NHS or social care, and we actually have over 350,000 users across health and social care of our software. We have 30 acute trusts running our PAS EPR, 38 trusts using our e-observation platform. 60% of the country runs adults and children's social care through Liquid Logic. Medicines management, which we're going to focus on today, is deployed in 350 hospitals in the UK and abroad, delivering 2.4 million prescriptions and 11 million administrations a week. We cover 20 million citizens with our shared care record, and then just less than 17 million with our population health analytics platform. And then we also cover 6.4 million children with our child information system, and we are the provider of the national immunisation service for both COVID and flu. So that just gives you a flavour of who we are. Next slide, please, Rob. Has that moved ahead, Rob? Yeah, great, thank you. And just to give you an idea of where we're working, this is just kind of heat maps of where we're working in England. Obviously, we're particularly with medicines management, we're doing work in Wales and other parts of the country and world. So Rob, if we kind of get on to the questions, and could you just tell us a little bit about yourself, about CareFlow Medicines Management, and also, you know, why you joined the Care Alliance?
Okay, so can you hear me, Jonathan?
Yes, I can, Rob. Yeah.
Great. Yeah. So yeah, good afternoon. Thanks, Jonathan. Yeah, it's great to be part of the Care Alliance. My name's Rob Blay, everybody. I'm the Chief Executive of CareFlow Medicines Management, as introduced, originally called Wellsky International Limited, and even further back, so some of you may remember us as JAC. We've been around the UK medicines management scene for many, many years, and I've been here with the company for the last 18 years. Having formerly worked in other clinical areas and way back in the day for the NHS. We're really delighted about the acquisition and joining the Care Alliance. As Jonathan has outlined, when you look at the reach that System C and Graphnet and Liquid Logic have, it's clear that they're covering all areas of the health and social care sector. And we're delighted to be able to fit in as part of that and to support that expansion of the ability to provide medicines and medicines management as part of all of those different sectors. So the joining with the Care Alliance really has helped to further expand our work in terms of rolling out comprehensive capabilities and functionalities for in the world of medicines, from e-prescribing right through pharmacy to the bedside and beyond. So personally, I've known the likes of Ian and Marcus at System C and Graphnet for many years. I'm delighted to join forces, as indeed, Jonathan, we've known each other for a little while too, in the work we've done in the trade association Tech UK. So it's been really exciting to move in that direction and to further really provide you know, a more comprehensive offering to the UK healthcare market and abroad.
Yeah, thanks, Rob. through Tech UK and now through joining forces as part of the Alliance, we've discussed some of the challenges of medicines management across healthcare. But what do you see as the key challenges?
Okay, so Jonathan, this is a really leading and open question, and I think it's really difficult to sort of pin it down to 2 or 3 items, because the challenges across the whole of the health and social care sector for medicines are quite numerous. And it really kind of reflects the fact that this area has been evolving and maturing in the world of digital medicines management over the last decade or so. And we're still some way off finalizing all of that work to get to a mature digital medicines management situation within healthcare. I think if I was to summarize it, I'd say really that we've got numerous challenges, mostly related at the moment to fragmentation of data and limitations across the healthcare sector in terms of incomplete records of data related to medicines. But if we would kind of break it down and explore a little bit of some of those challenges, I sort of put it into about 4 or 5 categories, some of which we've already articulated. But just to touch on a few. So, for example, incomplete or unavailable patient medication histories. If you look across, not just within the acute sector, within hospitals, but also across other areas of mental health, community, primary care, and you'll see that there are many areas where there are still paper-based systems in place for the management of medicines. And work is ongoing to digitize those areas, and has been for some years, but we're not completely there yet. Also, in other parts of the system, you'll find specialist areas of care where records are held in silos or in specialist areas, you know, things that spring to mind. Some of the areas around chemotherapy, for example, tends to be fairly siloed. Then you'll find other areas in the community and care homes where information is limited or unavailable. And in some cases, interoperability, which is, of course, the real sort of glue, the method in which we're trying to join up healthcare across all of these areas and therefore provide that more comprehensive histories, is indeed still a work in progress in many areas. And it's limiting the efficient flow of medication histories across the health sector. And so that in itself creates a challenge which has the potential to compromise care. And Jonathan, with your background, I'm sure you appreciate that, and it can create also unwarranted variation. So we're finding that fragmentation and the incompleteness of records is limiting the ability for efficient care and efficient, safe care, as well as generally efficiencies within the system. I think if we were then perhaps to sort of talk a little bit more, break that down, some of the other specific areas, care transition is an issue. So medicines reconciliation, Jonathan, I think when we talked about this is an area that you have personal experience of with your medical background, but medicines reconciliation is still a challenge across the health system. Often a patient being admitted to hospital comes in with records or the GP record, which has to be manually entered into systems. It's not automated, and in some cases it's incomplete. And so admitting doctors have limited information and have quite a tortuous route to go and find the full history of a patient on admission to hospital. But medicines reconciliation doesn't just stop there. It affects a number of other areas of the healthcare system as well. And before I continue around this sort of care transition breakdown, Jonathan, do you have first-hand experience of this?
Yeah, I mean, I think I do. I vividly remember being a junior doctor, asking patients for their homemade list, their prescriptions, phoning GP practices trying to get hold, or relatives at home trying to get hold of kind of key medicines record information, and then often having to make kind of key decisions without that complete information. And I don't think we've yet solved that, and I think in lots of places that it's still the same situation for those junior doctors. And I always used to actually feel a lot for, you know, not just obviously myself, but for other clinicians in the system, particularly GPs who are, you know, waiting for discharge summaries with medicines changes, which, you know, the TTOs, which were often delayed. So I think wherever you look in the system, and there are problems, and as you rightly say, there are some parts, you know, some care settings where it's just not catered for at all yet. So yeah, I have kind of real life world experience of the challenges and actually some of the safety issues that fall out of that.
And thank you, Jonathan, because, you know, that's the sort of the stories that we hear from the medical front line about the challenges with this types of things, and it goes beyond that. Sadly, the challenges are more widespread than that. You mentioned discharge, of course, and there's work ongoing to do that, and there has been a lot of progress in terms of discharge, electronic discharge. But if we come back to the general issue around transition of care, and why is it important? Well, it's important because you know, when you're transitioning a patient through their journey from with an episode of care from one setting to another, it's vitally important to have, for clinicians to have the right information at their fingertips to make the right judgments on what can be life-threatening decisions on medication. But other transitions between care settings, not just between them, but within them. We mentioned siloed areas in specialties, but, you know, we also are seeing challenges in terms of, in certain areas, in certain settings, where you're going from high dependency units to low dependency units, and the transition of care between them and systems that operate in those settings can also be challenging, to say the least. Outside of the acute, in the areas around social care, community, primary care, and the acute, the essential flow of information doesn't seamlessly follow the patient journey from one episode to another. And that, again, as we said, really does have the potential to compromise care. But if you consider that on a more regional perspective, and coming back to this whole subject matter, this is not a uniqueness to ICSs or to England. You know, we see medicines reconciliation high up the priority list in the national strategies in Scotland and Wales and other areas. So it's a fundamental area that needs to be addressed in a more robust way over time. And each region is operating, each devolved nation is operating slightly differently in this regard. But in Scotland, for example, their health boards are collaborating both regionally and amongst themselves to cover not just the acute sector, but the other care settings. And you know, we see that beginning to also become a focal point with the formation of integrated care systems within England. So within the broad remit of an ICS, you've got every setting there is. So you have primary care, of course, but you've also got things like care homes, nursing homes, hospices, community trusts, home care themselves, prisons, ambulance, acute, as well as the specialist and tertiary centres. And you think about that, medicines really form every part of those care settings in some form or another. And the ability to track and move data around for the benefit of all the clinicians involved as the patients follow their journey is clearly a mammoth task. And interoperability goes some way to resolving that. But as I said earlier on, it's still a considerable challenge in getting all of those care settings joined up. But that does lead to problems of transition of care. So work is being talked about. Each of those care settings are beginning to work. And I think the formation of ICSs, like in the other regions in Wales and in Scotland, have the ability to take this further and produce more regional care records or even national care records. So that's a particular area that we can tackle as we move forward. In terms of another area that's perhaps overlooked a little bit, but I think is another challenge within this whole world of healthcare and medicines management is tackling healthcare inequalities. So compliance of medicines and concordance or adherence issues remain a continual challenge. And there's some really interesting statistics around that. And of course, these issues are exacerbated by a lack of medication records in certain segments of society in the care settings. I'll explain a little bit more what I mean by that. But effectively, from a recent study in one region of the UK recently, it showed that up to 12% of readmissions into hospital were medication related, and that 2/3 of those were preventable. And they were preventable because they related to areas of healthcare inequalities, particularly around areas of compliance, where in certain sectors, for example, the elderly, who perhaps can't really comprehend, especially if they're self-administering clearly or get forgetful about their medications, those in certain mental health areas or who have mental health problems similarly, and not forgetting that there are sectors of the population where English is not their primary language. And the quality of care and their outcomes and the resultant over-ordering of drugs becomes a significant issue and can result in harm and result in readmission to hospital. And some of this can be tackled with better digital capabilities in those care settings, the ability to capture that information, to monitor it more effectively, as well as just relying on the carers for those individuals. So this is a particular area, I think, that is something that we're trying to address, but is certainly an important area to look at. I guess coming really kind of final area that I wanted to chat on, and that hopefully this will also, spur a little bit of a conversation between us, Jonathan, about data. But I describe it as really the lack of actionable data. So, we have a number of statistics that show in excess of £300 million per annum is wasted due to many of the issues we described. But the lack of actionable data across the whole of the health system is limiting and preventing tackling some of those issues. So with the lack of access to a comprehensive medication record and the history, it does limit us on our ability to deliver on other important initiatives that are challenges for medicine, such as medicines optimization. The ability to collate all that data to do effective medicines optimization. And again, I think, Jonathan, this is something you probably have some first-hand experience of. Other things like the structured medication reviews, which are required by GPs and others to do effective, and other teams to do effective medication reviews. And then, of course, there's some recent things with regard to primary care quality standards around medicines reconciliation in primary care. And that's not been achieved in the timely manner that's been required, in part because of the lack of available information. And then monitoring of key critical medicines across the sector as well. So you can pinpoint really across certain key sectors has been documented there are challenges with such medicines as opioids, diuretics, anticoagulants, antiplatelets, just to name a few. And the ability to have cross-sector care records with that information would improve some of that monitoring and avoid some of the challenges that are associated with it. So, Jonathan, I don't know from your point, again, thinking back to your sort of medical days, whether, you can relate to some of those challenges in those areas.
Yeah, I mean, definitely can. But I think if you look at the high level figures around some of this, like 5 to 10% of hospital admissions and medicines related, 2/3 are probably preventable. The overall NHS drugs bills 16.8 billion and rising rapidly. Then you realise why you can't just tackle this at individual organisation level. It has to be a system level approach and probably not a national approach, but an ICS level approach. And it's pretty startling, some of those figures. I always get startled when I reread them.
Indeed, indeed.
Thanks, Rob. Can we just change tack slightly? And lots of people have seen a raft of publications over the last few weeks, both but from government and the NHS. And I just wonder how you see CareFlow Medicines Management and the Care Alliance supporting those various strategies across the UK.
Sure, and I got a couple of slides to sort of help with this point, which I'll come on to. Comes back a little bit to the point is there are quite a number of strategies being publicized these days, and a lot of them are, you know, English strategies, but equally Scotland and Wales, Northern Ireland, and other countries have similar but slightly differing strategies. I mentioned earlier, for example, the support of medicines reconciliation is a major initiative up in Scotland. Scotland has the benefit of being organized into 14 health boards, and certainly we are very active in the vast majority of those. Most recently, we're doing a major implementation of a medicines management solution covering pharmacy, prescribing and administration across the north of Scotland, as part of their unification strategy to pull all of that together. But probably the most significant and most recent one has been the Greater Glasgow and Clyde Health Board, which is a huge, is arguably the largest, something like 8,000 bed group of hospitals across the UK. And they've just been rolling out and gathering a massive amounts of data as a result of doing the work with CMM, or Wellsky as they probably remember us. And Wales, similarly, we've been implementing a nationwide sort of pharmacy solution. They're really doing things on a nationwide, as well as doing, due to start an implementation of the prescribing in the out of hours services, the NHS 1-1 service, over the next year or two. And that's them. But coming back to the England and the ICSs, so there are a number of strategies that some of you will have heard of, and most notably things like what good looks like, the digital patient safety strategies, digital data strategies, and so forth. There's quite a number of them, and a lot of them really are focusing on improving things, not just at the local level, but certainly across the health and social care sector and at ICS levels. And of course, you've got the general philosophies of what an ICS is, which are being more matured and formed on a daily basis across England. To kind of put a couple of those into perspective, I'll try and just move my slides on here a second. So if we looked at the what good looks like framework and strategy, this is an interesting one that's been publicized, and it does talk about what good looks like both at an ICS level and also at a local level, at a sort of trust level and so forth. And you'll all be familiar with the requirement of ICS to collaborate across the entire health sector. But some of the things that they talk about, they really recognize and talk about some of the strategies around trying to solve some of the challenges that we've just been talking through. I mean, the first one that struck, obviously relevant to ourselves, you know, there's lots of stuff across not just medicines, but the whole healthcare scene, but use of EPMA to reduce errors. And they talk about leveling up and the use of scope of electronic care records, including greater clinical functionality and links to diagnostic systems and EPMA. And this is something that's, you know, leads on to the second point at expansion of clinical decision support. So we're really interested in all of this, and we have the capability with the Care Alliance to not just help to, as it were, level up and improve the clinical capability and functionality within the acute sectors, mental health, but more increasingly in community and across the ICS patch. And some of the work that we're doing with the Care Alliance is indeed in providing that opportunity to leverage the capabilities of the entire Care Alliance to deliver on some of that agenda. Expansion of clinical decision support. Yes, at the end of the day, once we've digitized, you know, the entire medication record, or even in the interim with what we have now, the ability to apply AI, logic, more decision support really turns the agenda looking forward to more advanced uses of the data and providing that improved clinical decision support, not just in terms of trapping errors and reducing adverse drug events, but in terms of providing more proactive decision support. And of course, through the Care Alliance, as well as other shared care records, we have the ability to work on that. And of course, with the Care Alliance in particular, with an area that I'd like you to kind of touch on a little bit, Jonathan, about the work that you guys are doing in this area around shared care records as really the central point from which we can deliver both this clinical functionality to the marketplace, but also in terms of capturing the data, providing that longitudinal medication record to all care settings, and integrating and interoperating with the various systems that are out there. And all of that, of course, it needs to be done. And we're active members and working, as you are, Jonathan. I know we talk at Tech UK level and also with PRSB on the adoption of standards to cross that to mature that whole setting. So one other thing that they also talk about in terms of what good looks like is the drive for population health, level health actions, using data to design and improve population health, and they use the word sustainability and transformation quite a lot. Well, transformation really only gets born out of having good solid data to inform evidence-based approach to transformation of healthcare. And so this will certainly help to drive through population health management the analytics side of things, which is really another exciting and very powerful area. Again, it talks about leveling up both at the local and at the ICS level, and this reduction of unwarranted variation, which has been talked about in many publications as far back as Lord Carter's reports and others about that, trying to drive out that unwarranted variation, which is costly, both in terms of care and outcomes, but in terms of cost as well. So those really are kind of my thoughts on that, and really just to kind of give you a summary of our vision of what this looks like. If you look at what's the capabilities and availability of solutions now to integrate with a shared care record at the ICS level, to provide that single source of the truth, which often is talked about, provide that really huge platform for data analytics, and most importantly, to capture as much data from all the different care settings to make it as complete a record as possible. Nirvana, you may say, yes, it's true, but it's kind of the passion that drives us in terms of trying to get to that point of providing that really, really comprehensive level of medicines management and data. So, Jonathan, do you want to touch a little bit on all of that last point before we move to see if there are any questions?
Yeah, I will, Rob, if that's okay. I mean, for me, the kind of structural changes that are happening in the NHS at the moment, i.e. integrated care systems, are about delivering a proactive health system, tackling health inequalities, as you've mentioned, tackling unwarranted variation, which you've also mentioned, integrating health and social care, and really delivering, value-based healthcare. I mean, I think we have to acknowledge that the NHS and social care is still dealing with a pandemic that's far from over, and what's been achieved in the way of particularly digital transformation has been a Herculean effort by those staff who've had to deal with an unprecedented pandemic. And so obviously all these changes come on top of that, so I think we all have to be cognizant of that. I mean, hopefully we've given you showing you that we've been thinking about integrated care for a long time. Liquid Logic became part of System C 10 years ago to help us support integrated health and social care, and this is only just really starting to happen. Graphnet joined to form the Care Alliance 7 years ago, but been pioneering shared care records for 25 years. And then we've since added the population health analytics that's played the key role in CIPHER and the National Immunisation Service that I mentioned earlier. And obviously it's pretty clear why CareFlow Medicines Management is a really important addition to the Alliance for all the reasons Rob has outlined earlier. So if I kind of focus in a bit on final thoughts around medicines management, just to call out a few things. Firstly, the benefits of e-prescribing are really well documented, but we still have unwarranted variations in adoption in care settings outside of primary care. It's really important we kind of do what we know works, and kind of we're now in a position to help provide that capability at an ICS level. I kind of talked a bit earlier about my own experience around medicines reconciliation, so I won't go over that again. But thirdly, having that complete medicines record also opens up lots of population health opportunities. Even very simple examples that are happening already are proactively monitoring for dangerous drug combinations and making sure those patients' medications are reviewed, or identifying people that are likely to be diabetic from test results but not on any diabetic treatment. Also, we also know that results that are seen in clinical trials are not necessarily replicated for all patients in the real world. We need real world evaluation, and that really does start to become possible when you have a full longitudinal record, including the full medicine record. And finally, the CIPHER program for us is specifically looking at 46 use cases, and that number is growing rapidly. It's forging collaboration and sharing across our ICS customer base. And actually, interestingly, each ICS is tackling their own priority areas, and we're really excited about the new opportunities that having CareFlow Medicines Management as part of the Alliance is going to give our customers. So that's just some final thoughts from me, Rob.
Thank you, Jonathan. A final sort of comment, you brought up the pandemic, and I think you're absolutely right. That's been a huge challenge for the NHS, and it's certainly not gone unappreciated. But equally, what we found is during adversity how adoption of digital actually in some areas was accelerated and improved, certainly in some of the areas we worked on. We've seen the work that went along initially with the setup of the Nightingale clinics, but then, like yourselves, actively involved in helping out with the vaccination distribution program, as well as providing significant data from all of those systems that were currently live in our portfolio for prescribing, looking at the whole prescribing of data and drugs across the last 12 months before the pandemic really hit, and then going on. And that's produced some really interesting data to help organizations like NHS England and NEX and SAGE and stuff to start that. And that's only a fraction of the market. So imagine what that could be. So I guess we started by talking about challenges, but I think that for us really at the Care Alliance, challenges means opportunity, and we can see some great opportunity to progress through the ICS arrangements and the other regional areas, the improvements in medication management and the reduction in some of these challenges. So I appreciate the opportunity to chat, Jonathan. I hope the audience found it of interest. And yeah,
I think just one further point just triggered from what you were saying, Rob. I think you're absolutely right around what was achieved, and for me that really showed that it wasn't a capability problem, but probably a structural problem. And I'm kind of hopeful that integrated care systems are going to cut through some of those structural problems that may have existed previously.
Yes, indeed. I couldn't agree with you more. Shall we turn it over to see if there are any questions? I don't know if John from HCN or Alan are on, whether you've been monitoring the chat. Have there been any questions, guys?
Yeah, for sure. I'll take over the questions. But first of all, I want to say a big thank you to Dr. Jonathan Bloor and Robert Tysall-Blay for talking us through that. I think that's a really good session to end the sessions of HTN Now today. And a reminder that there are other days this week to sign up for, so make sure you're signing up. We do have just 4 questions here to talk through. So the first question, and apologies that this was probably answered a little bit, but let's touch on it again for the sake of this. What is the plan for medicines reconciliation within CMM?
So medicines reconciliation within CMM is already available in terms of functional capability to record medicines reconciliation in the hospital settings on admission. What actually is being worked on, and actually being worked on not least within the Care Alliance, is the ability to take on board the information from primary care and then have an electronic integration with the secondary care markets. So this is certainly a high-profile piece of work, and we anticipate that being really worked on over the next 12 months and hopefully delivered as part of this program we've been talking about.
Brilliant, thank you. And we've had another question just come in and jump the queue a bit there, but how do you see the role of medicines management pharmacy techs in acute settings?
The role of pharmacy techs in acute hospital settings.
Acute settings, yeah.
In the acute settings. Well, I think, you know, a lot has been talked about the automation of pharmacy over the years. And you know, the importance for pharmacy technicians to provide, continue to provide that service, but also to provide that clinical advice as well as pharmacists do. So I think the role remains the same. It's certainly in managing, you know, greater volumes of data, greater volumes of work through the exceptional work that they do. But perhaps having more of a lean towards, you know, the sort of wider scope of delivering pharmacy services outside of their current remit. We've evidence of, in some areas, for example, that hospital-based pharmacy services are actually supporting community, for example. So we can see, you know, that potentially expanding and being the case. So I think there's quite a number of areas for pharmacy technicians specifically.
I think, Rob, just to add to that, I think there are lots of kind of digital roles, particularly in acute hospitals, emerging. You know, the CCIO, CNIO, digital pharmacist. So I think there's lots of opportunity in this space that maybe not have been just solely the traditional role.
Indeed.
Thank you. We've just got some. Oh, we've got another question in. How is CMM supporting virtual outpatient clinics, allowing the remote prescribing and sending to trust pharmacy or local community pharmacy? That's the first question.
That is a great question. I think the best way I can describe this is something that came out of the pandemic. And I'm going to name drop a joint customer of ours, which is St Helens and Knowsley. And they had an interesting situation during the pandemic where they were having to provide virtual consultation into a particular hospital, a care home type setting, or I forget, not much a care home, but certainly a remote hospital setting where the patients unfortunately were succumbing to COVID a lot, and the staff were, and they had to really, the GPs and others had to do remote consultations, like an outpatient consultation. And the ability to provide the digital capability to prescribe, review their medication history, and then additionally have linked through to pharmacy and dispensing. And to take that to what I believe was the second part of that question, is what was also interesting is how that evolved then in terms of the pharmacy side of things. So the drugs during the pandemic, you didn't want lots of patients in outpatient clinics sitting side by side. So they not only did virtual consultation, but they did a virtual pharmacy dispensing clinic, which was like a point and click in the car park. So you were able to roll up and pick up your medicines from the car park. So it really showed how innovative the health system can be in times of adversity. But it also showed that really underpinning that, we had the capability through CMM to support that with the data platforms and the functionality for both remote consultation and also remote prescribing and right through the supply chain from pharmacy to administration. Great question.
Brilliant, thank you. And there was a second part to that, which you may have started to touch on there, but I'll say it again. How is CMM supporting patient self-administration with patient recording digitally?
Patient self-administration is certainly something we're looking at. If we're talking really about patient self-administration within the home or those settings, that's certainly an area that we're looking to explore with better capabilities. We haven't got, I couldn't give you a sort of chapter and verse on how we're doing it, but clearly it involves mobile technology, the capability of using either existing or creating apps whereby patients themselves can record their own self-administrations. And philosophically, and part of the strategy that we talk about is not just about joining up the different care settings and the systems, but joining the patients. And the patients definitely are at the center of all of this. And if you've got ability to capture, their recordance and their compliance and capture that via mobile devices and other methodologies for that matter, and have that feed into the shared care arrangement, then we can really help GPs to monitor things more effectively, as well as for other clinicians and teams to monitor things. So definitely a move in the direction we're interested in, and things are beginning to come out of that. And we've actually had a couple of customers approach us about working in parallel with that. And so if that particular customer who posed that question wants to reach out to me, my email address is rob.blay at wellsky.com. We're in the process of changing, but it'll be very soon be changed to CareFlow. But you can reach us either via this media or others. I'll be happy to see what you're doing or what your aspirations are as we try to develop this yet further.